Welcome to this explainer. We're jumping right in today, translating small bowel pathology into high-yield takeaways with a rapid-fire surgical masterclass.
Here's the itinerary: anatomy adaptation, obstruction and ischemia, managing Crohn's, Meckel's diverticulum, and finally, neoplasms and carcinoid. Let's go.
Section 1. Anatomy and functional adaptation.
First clinical question: what's the primary site of iron absorption? The correct option is B, the duodenum and proximal jejunum. See, active iron absorption happens almost exclusively right there at the start of the small bowel using the DMT1 transporter inside those enterocytes. And here's a crucial exam throw for you. The terminal ileum has its own completely exclusive job, which is absorbing vitamin B12 and bile acids.
Moving on to question 2. When looking at bowel adaptation following a massive resection, which segment actually has the highest capacity to adapt? The answer is C, the ileum. It's a strict one-way street. If a patient loses their jejunum, the ileum steps up, undergoing villous hyperplasia to absorb those lost nutrients. But it does not work in reverse. The jejunum simply cannot adapt to absorb bile salts or B12. So, your ultimate exam pearl here? Ileal preservation is absolutely critical.
Section 2. Bowel obstruction and ischemia.
Let's look at question 3. You've got a patient with recurrent, crampy abdominal pain, nausea, and dilated loops of small bowel. What is the single most common cause of a mechanical small bowel obstruction in developed nations? The answer is B, postoperative adhesions. A patient's prior surgical history is literally the most dangerous risk factor we see today, driving 60 to 70% of these cases. Now for your exam pearl, incarcerated hernias are actually the global second, but they take the #1 spot in areas that lack widespread surgical access.
Question 4. When evaluating a complete obstruction, what's the most reliable indicator of impending or active bowel strangulation? It's B. It plays out as a progressive cascade. Step 1. Mechanical occlusion stops the blood flow. Step 2. That leads to systemic inflammatory signs, think tachycardia, leukocytosis, or a rising lactate level. And Step 3. Localized peritonitis sets in. The big exam pearl here: these distinct systemic steps are a massive red flag that mandate emergency surgical exploration.
Question 5 illustrates a truly terrifying clinical mismatch. A 70-year-old patient presents with severe, unremitting pain, but their abdomen is completely soft and non-tender. The diagnosis? It's B, acute mesenteric ischemia. See, early on, mucosal hypoxia drives this incredibly intense visceral pain, but because the tissue hasn't actually progressed to full transmural gangrene yet, there's no rigidity, so the abdomen stays soft. That's your classic exam pearl right there. Pain entirely out of proportion to the physical exam.
Question 6. Tracing the pathogenesis of that exact ischemia, which vascular structure is most frequently occluded by a systemic arterial embolus from AFib? The correct option is B, the superior mesenteric artery, or SMA. Because of its large caliber and that really acute takeoff angle from the abdominal aorta, it acts like a catcher's mitt for clots. Your exam pearl for this one: those emboli usually lodge about 3 to 10 centimeters distal to the origin, which is why the proximal jejunum is often spared.
Section 3. Managing Crohn's disease.
Question 7. For a patient who needs surgery for a Crohn's disease complication, what's the primary operational rule for surgical resection margins? The answer is C. Limit the resection strictly to the grossly diseased segment. Remember, Crohn's is a pan-GI disease. Chasing microscopic margins isn't going to surgically cure it. So your exam pearl is that maximum conservation is the absolute rule here to prevent short bowel syndrome.
Question 8. If a surgeon wants to entirely bypass resection for a long fibrotic Crohn's stricture, what is the standard surgical management? It's B, stricturoplasty. By making a longitudinal incision right across the narrowed segment and then closing it transversely, surgeons can actually widen the lumen without removing a single piece of tissue. It's the ultimate exam pearl, a highly effective 100% bowel-sparing technique.
Section 4. Meckel's diverticulum.
Question 9. What embryological structure fails to obliterate during development to form a Meckel's diverticulum? The answer is B, the vital line or omphalomesenteric duct. When this doesn't fully obliterate, it leaves behind a true diverticulum that contains all 3 layers of the bowel wall. And your classic exam pearl, you'll typically find this on the anti-mesenteric border of the ileum.
Question 10. Imagine a 6-year-old boy presenting with massive, painless rectal bleeding in a positive technetium scan. What specific tissue type must be present inside that diverticulum? It's B, ectopic gastric mucosa. The pouch itself isn't really the problem. It's this misplaced, acid-secreting stomach tissue hiding inside that violently ulcerates the unprotected adjacent ileum, causing the bleed. The exam pearl here? That nuclear scan works beautifully because the 99 MTC pertechnetate tracer binds preferentially right to those gastric cells.
Section 5. Small bowel neoplasms and carcinoid syndrome.
Question 11. What is the most common primary benign neoplasm encountered within the small intestine? It's C, an adenoma. While benign tumors in the small bowel are generally pretty rare, adenomas take the top spot as the most common histopathological group, followed by leiomyomas and lipomas. But crucially, as the exam pearl points out, true adenomas possess malignant potential and absolutely require excision.
Question 12. Moving over to the malignant side, what's the most common primary malignant tumor found in the small intestine overall? The answer is B, primary adenocarcinoma. These account for roughly 35 to 40% of all cases. And note the exam pearl here. Adenocarcinomas uniquely favor taking root in the duodenum, whereas neuroendocrine tumors heavily favor the distal ileum.
Question 13. For a patient with a neuroendocrine tumor to actually manifest carcinoid syndrome symptoms, like flushing and diarrhea, what has to happen? The answer is B. It's a specific sequence. Step 1, the tumor in the distal ileum secretes serotonin. Now, if it stays there, the liver just metabolizes it. But steps 2 and 3, the tumor metastasizes to the liver or other extraportal sites. That physical spread allows the hormones to bypass first-pass metabolism and dump straight into the systemic circulation. Your vital exam pearl? A systemic syndrome absolutely requires that extraportal spread.
Question 14. Once those hormones are systemic, they travel to the heart, but they only cause valve defects on the right side. Why is that? Take a look at the comparison. The right heart gets battered by those vasoactive peptides, but the left heart, it's completely spared, which is answer C. Why? Because pulmonary monoamine oxidase inactivates the serotonin in the lungs. The example here brilliantly illustrates your body's innate defenses. The pulmonary capillary bed protects the left heart by enzymatically scrubbing the blood clean before it ever reaches the mitral and aortic valves.
We've moved systematically today from functional anatomy through strictures, embryological ghosts, and systemic hormones. Looking at all these principles together leaves us with a pretty fascinating final thought. From preserving the ileum to sparing tissue and Crohn's, the overarching principle of the small bowel is radical conservation. How much of our surgical success relies on simply knowing when to leave anatomy intact? Thanks for joining me on this explainer. See you next time.